weeks prior can be milder, but they still have the prevailing mood is depressed. But on that day, when you see, they say, "Oh, today I feel much better. I feel a little bit better." So the mood can be described. The mood and affect sometimes used interchangeably, but in short, the mood is the subjective experience of the patient. The effect is the objectively you can see that. So it linked to particular aspect, object, or it can be the transitory. For instance, like you can divide the abnormality of mood and emotion. Sometimes the changes in nature, the altered of the mood too. Anxiety, depression, elation, irritability, the angers, the nature of the mood, or some book says the maybe the prevailing mood, the things that the patient described, and it will be observed with other associated factors. For instance, if they have say, I feel anxious, I feel worried, sometimes you can see they have all the muscle tense, they are agitated. And if they said, I am depressed, so we can see there will be sadness looking at the face, and also the psychomotor slowness. That all these things can be seen during your mental state examination. And the mental state examination occur the moment you call the patient to see you. Before they speak to you, you can describe their movement, their general appearance. So this is part of the mental state examination. So in mental state examination, do not start when you ask certain specific question, but it started the moment you talk to the patient. You're going to describe in certain area. Verbality of the mood. So the affect verbality. So it varies in relation to person's preoccupation and circumstances. So if let's say we found out the variation is a lot, so that we call mood lability. Mood label. Sometimes in one setting, when you look at the patient, they are describing themselves that I'm happy, and suddenly they become angry. So suddenly they become manic. So looks happy. So if let's say very extreme variation, this can be called as emotional incontinence. What is that? With slight jokes, the patient can laugh inappropriately. So it can be seen particularly in the case of brain injury and dementia. I mean, you're supposed not to um, laugh for the very very minor or minor things. So this is whereby they can't control their emotion, and when they heard about something sad, they straight away cry until they maybe the crying comes in terms of uh, berguling-guling, turn into the regress to like a child. So this is extreme variation. You can see the emotional incontinence, quite common to be seen in the patient, elderly with dementia, with the neurocognitive disorders. And if it is reduced variation, there's not much variability you can see in them. So whenever they talk about many other aspects, the face, the effect, the movement, the body language shows blunting or flattening, which you can see in schizophrenia or chronic psychotic. Severe flattening is the patient can look unconcerned about surroundings. So they appear like an apathy. They no no emotion at all. Okay, so it can also change in the variability of the mood or the effect also can be seen in terms of not in keeping with the person's circumstances and thoughts. So this is where we call incongruent or inappropriate effect. Somebody will talk about death of their mother, but they can still smiling, giggling, and as if not doesn't show much in their face, in their facial expression, in their way of their speech, their movement. So this is incongruent. It can be seen in schizophrenia, psychotic, or even in the brain disorders. I mean, organic brain, the stroke. But please do not mistakenly interpret from a shy person. I mean, the person who feel shy or they don't want to show that. So you can see that they're still sad, but they are just smiling because they want to hide their emotion. And this can be seen that actually she is shy. She doesn't really come forward to tell yet. So, but they laugh because to reduce, not to laugh, they smile to reduce their own anxiety. So this is congruent. Okay. Any questions so far? Tada. So what are the clinical association? The anxiety disorders, feeling dread and apprehensive. In the phobia, you can have the mood of fear, anxious. So this is the mood. In depression, you can have a so sad, low, anhedonia, lack of pleasure. And in many of bipolar, you can see the elated mood, that irritability. Irritability you can see in depression, many demented also sometimes irritability, substance induced, and irritable is a sign of stress as well, the acute stress. So irritability is not that specific, but it can occur in many situations. I mean, you are anxious also, you tend to be snappish, irritable, the anger part, the upsetting part will also present. So this is not that specific to certain diagnosis. But elation you can see more in the bipolar, in manic phase, or in hypomanic phase. And if you have phobic disorders, you can see them as fear, anxious, avoidant. We have discussed this in the seminar of anxiety disorders. Okay, what about disorders of memory? So any questions so far? We are moving to disorders of memory now. Hello.
No problem.
So you can see this when you look at the mental state examination, then you can describe this what sort of under the mood, under the speech. You can see, you can check and you can put your observation. Yeah, amnesia. Disorders of memory. Sometimes we say amnesia, failure of memory, amnestic syndrome. Paramnesia is distortion of memory, not memory. Paramnesia, or sometimes they say dysnesia, dysamnesia. So this is to show distortion of the memory. We can explain the memory in details, but we say sort of like we have some memories, but I can't remember that well. So amnesia is failure of that memory. We can see some of the disorders of memory in terms of immediate memory. So under your MSE, something at the later part, you will be checking or do your mental state on the cognitive function. Under cognitive function or cognition, you will see that. By the way, sorry, have you had your mental state examination class?
Yes, bro.
Yes.
Okay, so this is will be wonderful information for you to go back to your lecture on memory on the MSE under cognitive assessment. Cognitive part, it will include attention, the sorry, consciousness, it will in the cognitive function, yeah, the conscious level, orientation, memory, attention concentration, the general knowledge, the abstract thinking, the abstract thinking, not just abstract, concrete thinking, the mathematical ability. At least we want to get some ideas on their cognitive function, and memory is one part of the cognitive function. And this is why do I choose to discuss on the disorders of memory, because this is the very common presentation or complaint by our clinical population. They will come to us and say that I'm forgetful. I'm and looking at the patient, we don't think that they are having demented, because those people who come may be very young. So what is the causes for the memory disturbances? So it can be the depression itself. Depression can present it with depressive pseudo dementia. They can't remember well when you are depressed, because of there will be difficulty to focus and retain the focus, the attention and concentration will be affected. So when you are not focusing, there will be no registration of the event. So when there is no registration, there will be no recall. So the patient will say that I forget many of the events. For all you know, they are having forgetful, the cognitive issues because of the depression itself, or it can be dementia, it can be delirium, it can be other neurocognitive disorders. So recent memory, retention of events, information over few days. So the memory can be divided into immediate, recent, and long-term or remote memory. And for the recent and immediate memory, usually the patient can be regarded as having dementia, because their long term usually good dementia or delirium. Okay, now mm, what apart from the understanding of the memory, so we can also look at either the recall or recognition or retrieval issues. So sometimes patient cannot recall. We ask them, what do you have yesterday? They said something else that I do not eat. So they don't have memory. They can't remember. And sometimes they become very disturbed with, because the inability to recall, they sometimes become restless, and they feel stressed because they cannot remember many things. Recognition is sometimes the patient may not be able to recall, but when we ask, they recognize faces, they recognize. The only thing that they can't recall, they recognize the words, the numbers, but they cannot recall. Sometimes they can recall based on cue. So when we say, do you remember what do you do yesterday? They said, no, I can't remember. But when we show any photos or any show, I was here yesterday. So the retrieval part is that an issues here. So either patient can be recall or recognition. So in dementia or delirium, the recall of recent events are affected. They cannot recall. What about recognition? Perhaps in dementia, they could probably have difficulties to recognize as well. But sometimes they can recognize the familiar object, familiar places, familiar face, they still recognize. In organic condition, they can have amnestic disorders. Amnestic disorders is the memory, the amnesia just now that we talking, we thought. So recent and immediate memory loss. This is one of the amnestic disorders refer to recent or immediate memory loss. So it can be anterograde amnesia, it can be retrograde amnesia. And if let's say someone come to us and say, I cannot remember anything, even about myself, so it looks like psychogenic rather than organic. What is psychogenic? That means it is more towards a psychological malingering. People wanted to malingering is so called like manipulative and making the symptoms in order to get for another gain. They say I can't remember about the situation. I can't remember even where am I, where about. I can't even remember myself. So let's say in the case of murder or something, which is so we know that probably this person malingering to get the gain, so they will not be punished or not be jailed due to their offense. Yeah. Okay, so anterograde amnesia is the memory impact between the complete unconsciousness and regain consciousness again. So I give you an example. Somebody met with the accident. So this person has a severe axonal injury. I hope you know it's axonal injury. So the person, when we see them, they are conscious, they are alert, they are eating, they are writing, but sometimes there are other behavioral disturbances. And when they regain from the just before the accident, and when they regain consciousness, they don't know what is happening in between. So this anterograde amnesia happened to my best friend who was involved with the accident. So she has brain injury, and this now she regained the conscious. I mean, the she is when we see that when we see her, she is conscious. I mean, she even she even recognized me when I visited her in the hospital. However, she doesn't have that memory that I visited her until recently. So we showed to them that this is me. We took a photo. I was talking to you, and then she said, "Oh, I don't have the memory of that." Yeah, because she has anterograde amnesia. So she could not remember even the accident itself. She cannot remember. She just remember she's driving a car, and then she didn't know that she was involved in the accident until I think after 3 months, a few months later, 3, 4, not 3 months. It's more than that. So slowly, and then she started to realize that, oh, she knew that she's, when they show some photos that this is your car, you involved this, then she said, I don't have any memory of that. But so the complete unconsciousness and regain consciousness again. So what is the explanation from her? I asked her, um, what's happening? So she said, she just think that she's in the very long sleep. She's dreaming. She is sleeping. So that's how she is described. She said that I don't know, but I think that I'm sleeping too long that I've been sleeping, and sometime in my dream I meet with some funny things. But one thing about her, I guess, because she came back from Hajj, and she had some of the activities that she prays a lot. So when she in this anterograde amnesia, what normally that she will do is she always asks her son to go and pray. However, the son becomes stressful because after one another say, okay, go and pray. So in one day he has to pray many times, because and my friend said he has no memory of that. He just remembered that he has been sleeping and dreaming. And he said when she is going to wake up from this sleep, subhanallah. So this is the thing that we do not know very much when Allah create us. MashaAllah. And this is the experience that coming from my friend, and one of my neighbor also goes into the almarhum, yeah, my neighbor, very nice. And he was intubated in the ICU, and then for the diabetic, so sort of like coma. And then but during the conscious and unconscious, he's called the nurses, and he said that to the nurses that you should look after. I mean, he's in interacting in the ICU. When he regained his consciousness, he just told me that he's actually died. He has died. He's gone into grave, and suddenly he wake up. And when the situation occur, when he is called, the nurses actually in his dream that the nurses are uh, the nurses is blocking or preventing him to sort of like some funeral, something, some kind of that. So mashallah, we just know that Allah can give how to say this, yeah, Allah probably choose some person to feel it and to go through this. So I guess my neighbor has gone through one episode of he said that I died, but I wake up again. So he can see himself clearly that people busy to during that funeral. But mashallah, that after that he's a very pious and one of the best neighbor that I met, and inshallah he's in the good position now. Okay, so the anterograde amnesia, so the memory impact, but he can't remember what is happening in between that. Retrograde amnesia is problem to recall events prior to the unconsciousness. So they can't remember what before that. The memory they have is just when they regain consciousness, then that's the memory that they have. But they probably cannot recall some of the uh, event that they've gone through. I mean, they can't remember probably the episode of they went to medical school if they are doctors, but then they realize it is that retrograde amnesia. So it can be temporary, yeah. It's not necessary to be permanent. Okay, well, sometimes disturbance of recognition. Deja vu is the sense of familiarity. So we recognize certain situation. We said that I've been in this place. It looks like it does happen to me before. So this is what we call deja vu, the sense of familiarity, although that's the first time they are in that situation. What about jamais vu is the sense of unfamiliarity. I mean, every day you go to the ward, the suspect, and then suddenly you went there in the one morning and say, this place is sounds as if I'm in a new place. So this is the sense of unfamiliarity. So disturbance of recognition of the surrounding. You remember just now I said the memory can be disturbance of recognition, and also can be the disturbance in terms of the recall. So the recall you can see in the psychogenic, in the organic brain and the amnesia. But if the recognition of the memory, we call can be also confabulation. Confabulation is a false memory. So many of the patient who has dementia or neurocognitive disorders, they have no memory. So in order to fill up the memory, they will tell us some false memory. So many of the relative will say that why the my mother or father who is old enough to have demented, so he is telling lies. He say things that which is not being done, because actually what is happening is the mind is trying to um, full try to fill the memory gaps, the period of when they have the false memory. So the period that they have no memory, so they did a new memory which is not true. For instance, if an old lady, I have, and again, one person that I knew, now also she sometimes confabulate. So the confabulation is because they want to fill the memory gaps, the memory that they have. They have no memory, so they create one memory, one cerita lah. Occasionally you see the demented patient, yeah. So they will tell you that, oh, this morning I have this, I have people do not give me food. So it's create havoc among families sometimes. Okay, what about some other things that you talk about this consciousness or the cognitive function, disorders of consciousness. Sometimes we have the patient conscious is the awareness of the surrounding. The patient can have coma. Sometimes patient can come with clouding of consciousness. What is clouding of consciousness? The attention is poor, the concentration is poor, orientation also poor, and the thinking become very muddled, confused, can't think properly. So they cannot attend to your question. They cannot concentrate, and they can't recognize the people, the time, the place sometimes. So this is what you call clouding of consciousness. You can see this in alcohol, withdrawal, or some encephalopathy, liver impairment, or some hypoxic brain. We can have this. What about stupor? Stupor is immobile, mute, unresponsive, but they are conscious. How do you know they are conscious? They can still follow your hand, your movement. The eyes is following, but they are immobile. They don't want to work, to move. They are mute, as if they are unresponsive. And stupor is one of the symptoms that you can see in catatonia. Catatonia is the under movement disorders. Okay, what about confusion? Confusion is inability to think clearly. Sometimes you say, Dr. Nora, I'm confused with your explanation. So this is the literally we thought about we understand about confusion, which is also true. But here the confusion that we give more clinical significance is when we have the acute confusional state, or we call delirium, whereby the thinking will be very slow, sluggish, and muddled. And at the same time, we have impact our conscious level, the impairment of conscious level together with the, so we can't recognize, we cannot concentrate, we cannot, it's a fluctuation between memories. So this is we call acute confusional state delirium. So confusion is inability to think clearly, which is sometimes we also cannot think clearly if too much information. Okay, what about attention and concentration? Is part of the cognitive function as well. So the situation is we cannot focus and we cannot maintain the focus. Attention is the ability to focus to the subject, and ability to maintain the focus throughout the interview, throughout the conversation. This is what we call concentration. And attention and concentration will be affected in the case of depression, anxiety. These are the two common, and sometimes schizophrenia, or even in the acute confusional state. However, how do we know that in the clinical setting that their attention and concentration is bad? Particularly if we are talking about anxiety and depression. Because they come to see you, they are conscious, they are not in the acute delirium, but they said that I can't focus, I cannot concentrate. So it can be seen in terms of the, when we test the memory, the recent memory will be impaired in attention and concentration. Okay, so the patient cannot even recall the 3 or 5 subjects that we give to the patient. Then we so, and sometimes patient ask us, what is that? What is your question just now? So they keep on, because they are not focusing. So this is the issue in the attention and concentration. Apart from the disturbances directly to the memory or cognitive function, but it also can affect it can be present in depression and anxiety. And you can see this when you start talking to the patient. You need to test at least the attention and concentration through the memory test. So they will have recent memory affected, because when you cannot concentrate, you cannot focus, there will be no registration in the brain or in the mind. So this is where you lost the recall as well. Okay. Now, this is my last slide, but I hope any question from disorders of memory or cognitive function. Another part of the disorders of cognitive or attention and concentration that you can see in your MSE is your insight and judgment. So sometimes the insight can be partial, can be poor. But the insight is the ability to recognize the symptoms is due to some illnesses, and the needs to change the needs to the attribution to that. The patient can explain, oh, I have depression because of I can't sleep, I have poor memory, I've been crying. So all the patient can relate that the symptoms that they have is belong to certain diagnosis. And not only that, they are willing to follow the treatment plan. So this is another part. You can have the poor insight in schizophrenia. They don't even know why, they don't believe or they don't accept that they are having schizophrenia. Okay, that's not in my slide, but I hope that you can follow. Now, what about the disorders of motor or movement disorders? Right, we can have um, number one, the tics. Tics can be normal to some people, but tics also associated with obsessive compulsive disorder. And sometimes you can have tics disorder, the impulse disorders in the DSM-5. So tics can be vocal tics, can be verbal, vocal and sorry, motor tics and verbal tics or vocal tics. So tics is the regular. Tics is irregular repeated movement involving a group of muscle. You can see the patient involved by some the facial muscle, maybe some eyes, palpebral muscle. So it tics sideways movement of the head. So keep on. If you can see my picture here, sometimes patients just irregularly they just move their head. This is the irregular movement, repeated irregular. Okay. What about mannerism? Mannerism are repeated movement. It can be regular, it can be irregular, but mannerism is the repeated movement, but it is regular. Okay, mannerism is regular. Tics is irregular. So regular abnormal movement seems to be have purposes. Mannerism is have purposes. Um, for instance, like the patient may be do this tabit spring salute, which is very common example that we give. So there is a purpose. Purpose of mannerism is have regular repeated movement. Tics is irregular repeated movement. It's uncontrolled mannerism. And tics more prominent when the patient under stress. And tics are associated with obsessive compulsive disorder, can be in Tourette syndrome, also can have tics, right? So stereotypy is tics is irregular, stereotypy is regular repeated movement, but no purpose. For instance, like they keep on repeatedly change position, same time. So there's no purpose. Patient maybe rock here and there, but no purpose. So what's the purpose? No purpose. The stereotypes. What about catatonia? Catatonia is a condition of increased muscle tone. So in DSM-5, there are criteria to diagnose catatonia, such as the patient may have waxy flexibility, may have because the situation is increased muscle tones, but the conscious level is intact. Yeah, is intact. It does not interfere with the conscious. So catatonia increased muscle tone, and some will have flexibility, or we call it catalepsy. Catalepsy is the term to describe the tone in catatonia. So they can have catalepsy, and it is different from cataplexy. So you must uh, say that and put it correctly. Yeah? Cataplexy. Cataplexy is sudden loss um, of the muscle tone. That is cataplexy, sudden loss. Okay, posturing. Some of the patient chronic in schizophrenia or psychotic, they are very severe. They can adopt some posture for a long time. Maybe they just be at one corner. The posturing, they adopt some sort of posture. Maybe posture macam rukuk ke, macam sujud ke, but it's a long way, long time. I mean, if usual people, they will feel tired of in that posture, but for them, they don't look like they are tired. They just adopt this posturing for quite some times. So maybe at one corner, they just adopt some posture yang tunduk, certain part. So they can be in that posturing. Waxy flexibility is your movement is wax. Okay, you can maintain certain condition. So whenever your limbs or your body being done to another position, you will maintain in that position again. So waxy, dia macam lilin lah. So you can the person can be, they are in catatonia or in the situation. So we can shift, we can move their limbs to become and they can remain in this posture for sometimes. What is grimacing is the abnormal movement in the of the mouth. Sometimes it can be the side effect of medication. It can be tardive dyskinesia, whereby you can have the movement at the oral facial muscle. Negativism is you do the opposite, which is being asked. If let's say we say to them, please, when you are, please raise your hand. So they don't want to raise their hand. The negativism, they just do opposite. Please raise your hand. They just drop it. When they are in the raise position, they will drop it. If they are dropped, they will in the drop hand limb position. They will. So it's always doing things opposite of being what it has been asked. So let's say we persuade them to follow us, they resist. So this is negativism. What is echopraxia? Echopraxia is they imitate your movement. Echolalia, repeatedly words. Echopraxia is repeated movement. Follow the person. The person to maybe the therapist. So when you use when the other person is doing something, so they just follow. Mitgehen is the situation whereby we call extreme cooperation. Mitgehen is another movement disorders or motor development disorders in terms of if let's say you are in the posturing sometime, you are in the posturing, not you lah, the patient is in the posture, adopt certain posture, maybe with the slightest touch with our finger, the patient move towards something else. I mean, the extreme cooperation. In the usual normal circumstances, if you push with one finger, it should not move the patient. But once you move that, you touch, you push with one finger very slowly, but they can walk very fast. So this is extreme cooperation, too much cooperation. Mitgehen, yeah. And what is ambitendance? Or ambitendance is the situation whereby the alternate opposite movement. Ya, maksud dia alternate between the opposite movement. So they keep on when you notice what are they doing, probably what will do, they wanted to shake hand with you but they withdraw. So repeatedly, so dia macam was nak buat tak nak buat, nak buat tak nak buat. So this is ambitendance. Ambitendance in the movement, but the feeling will be ambivalence. Nak buat ke tak nak buat, nak duduk ke tak nak duduk, nak makan ke tak nak makan. So it will be like baru nak suap makanan, then they didn't do. So the opposite behavior. This also can be observed in some of the patients who has been having chronic schizophrenia. Yeah. Okay, I guess that's all I want to share with you. Any question?
Assalamualaikum, Doctor. Can you hear me? I just want to ask regarding what you say, abnormal movement right just now. Can we call it as dyskinesia? The first one.
Okay, dyskinesia is your part of the abnormal movement as well. But the kinesia is your the movement, the tadaf dyskinesia or dyskinesia or sometimes chorea is all under movement disorders as well. So it is more the dyskinesia is not stupor. So it is another term.
All right, Doctor. Second one. Do you familiar with the words melatah, Doctor?
Yes, latah, yeah.
Melatah in Malay culture, right? So
yeah.
Is that considered as abnormal things?
Yeah, melatah must have the echolalia, kan? Dia ada echolalia, dia ada echopraxia. Okay, so it is in the culture. So you repeatedly do that. So kalau patient, if a person, sometimes it's an extreme cooperation as well. You just touch them, but they can blurt all these words. So echolalia, echopraxia. Whether is this fall into certain disorders? Yes, we need to. But our society, our culture is part of the culture-bound syndrome, whereby latah occur in the South Asia Pacific. However, this latah also a presentation of some anxiety issues that person can have. So that means they have anxiety disorders or they have something, but it is because I have a patient who is actually, when he was very tense, so all this repeated movement comes in, and she also has this echolalia, echopraxia, and latah. Once we treat the condition of actually she has GAD, depressed, and some issues at that time. Now after we treated with antidepressant, there's no more latah, no more echopraxia, no more echolalia. So we have to investigate whether can be part of the culture bound syndrome, latah, amok, the elapse. So kalau dia berlaku di other culture, probably it will not be called latah, but it is a presentation of something else, of psychotic as well. I hope you understand.
All right, Doctor. Thank you so much.
Okay. So does eyes twitching counted as tics? Yeah, it's irregular. Some people they have this clip mata 2-3 kali, and you can see them more. The tics is more prominent when the person is under stress. Usually associated with some obsessive personality, some anxiety as well. And the more we put the patient under stressful situation, the more you can see the tics. Anxiety disorders need to be ruled out as well. OCD. Okay. Siapa tanya tu? Mama Azhan. Right. Any other question?
Assalamualaikum, Prof.
Yeah.
One question about
where are you?
Repeated.
Sorry. Maybe I want to see. Nobody open their camera.
I continue, Prof.
Yeah. Samba, yeah, okay.
My question about mannerism. Can Prof said repeated regular movement with purpose. So the purpose is the movement itself have purpose, or the patient does the movement with purpose, like want to get attention or something else?
No, the movement, when we clarify the patient, so the example usually we give is the saluting movement. So it's a purpose, like you salute, you show respect to people, you salute. But if let's say a patient keep on rocking, there's no purpose of that. So not to say that now coming to get attention or not. Okay, this is where the other step, whenever we see all this movement and the pattern, let's say the child or the person head banging, sometimes is for attention. This is not movement disorders. This is purposely, because it is not regular. Remember that? Mannerism, stereotypy, and tics. So mannerism and stereotypy is regular. So one day regular. Tapi kalau nak ambil attention tu, dia tak boleh regular lah. Only that purpose. Boleh Okay. Any other question? Okay. So I hope that with this information, the reference is, you can always look at the Kaplan, and also if you have the textbook Oxford of Psychiatry. So I usually found out the Oxford textbook psychiatry is quite easy to understand, and of course these are two the textbook that usually we use for undergraduate. Okay. Any other question? Tak ada. Okay, Alhamdulillah. I can share my slide with you all. You can have that. But of course, the explanation mostly coming from our class. Okay, so Alhamdulillah, we shall adjourn, and now it's 12:48. I think this is a long day for you all from morning until now. 10:30 you all done rested. Okay lah. Okay. So thank you very much. We shall adjourn with the surah Al-Ans and Tasbih Kifarah. Okay. So happy weekend, yeah? InsyaAllah. And for each of the group probably need to get in touch with the supervisors so that we can do the presentation, the psychoeducation. Not to worry, next week inshallah. Next week is your last introduction, right?
Yeah.
So get in touch with your own supervisor inshallah, and send the you get the material to us lah, to the email. Okay. So, Assalamualaikum.
Thank you, bro.
Thank you, bro.
Thank you, bro.
Thank you, bro.